Is Friday, January 13th, and we're here again in the House Healthcare Committee. And we have a very important, but often not forgotten, but
under the radar.
Thank you. Agency within state government. I think it's with. It's not.
I'll tell you all about it.
How much we don't know, but anyway, Vermont Program for Quality in Healthcare is here with Catherine Fulton, and they are doing amazing work in our state. So we wanted to get them in early, give an overview. So we'll let you go through your presentation, and then we can open it up for questions. Or do you want questions during the presentation?
That's your choice.
Okay. Well, we're pretty good at asking questions. And then if we don't feel like we're getting through, I'll put a stop to the questions to make sure we get through the whole presentation. And we're going to do introductions since many of us are new. And just so you know, I have taken the liberty of adopting a somewhat informal committee in that we use first names. So I hope that's okay with you.
Absolutely.
So I'm going Bobby again today.
All right, Dr. Charlie Trivio from Caledonia One, which is Martin, and I represent Reigate and Waterford as well.
Okay, pleasure to meet.
My name is Joe Andriano. I live in Orwell, but I also represent Shoreham, Whiting, Sudbury, and Hubbardton. Nice to meet you.
Nice meeting you.
Alan DeMar, I represent Montgomery and Enosburg, District 7.
Nice to meet you.
Alyssa Black, and I represent Northern Essex.
Lori Houghton, Essex Junction.
And Topper McFawn, I represent Barrytown and a part of Williamstown.
Nice to meet you.
Mari Cordes from Lincoln, represent Bristol, Starksboro, Moncton. I'm also a registered nurse that loves quality projects.
My favorite. You again.
Casey Berbecco, and I represent Winooski.
Leslie Goldman, Wyndham 3, Bells Falls area, and I'm going to echo Mari because I think it's the coolest.
Art Peterson, I live in Clarendon, represent Wallingford, Clarendon, West Rutland, or Peace Rutland.
Nice to meet you.
Great, so I'm going to turn it over to you.
Well, thank you. And for the record, Kathy Fulton, Executive Director of the Vermont Program for Quality in Healthcare. And it is a joy to be with you here today and have this opportunity to give you an overview of our organization. We are not a government entity.
As soon as I said it.
But, we do a lot of work with the state. So that's an easy misconception. But we were established as a 501c3 back in 1988. We're actually very unique and innovative in that we are one of the earliest independent quality assurance organizations in the country. I don't usually brag about being older than anything. We're older, the Institute for Healthcare Improvement. And we actually have a letter from Don Berwick from our early days and funding under the Robert Wood Johnson grant that the organization first worked under, doing clinical quality guidelines. And he recognized our early work. So, it's been we're going into our 35th year. So, we have grown with the industry, grown and changed and evolved as everything has done. So, happy to share our current work. And in 1994, the Vermont State Legislature established the 9416 Quality Assurance statute, contract, and build back funding for our organization that is, core and supports our core work, but it's capped at a 75% of our operating budget. So I'll tell you a little bit more about the other funding as we go through the presentation.
Okay, I'm going to stop you right there. Claire, are you doing the presentation?
I am.
Okay.
So if you could just tell me when to.
I'm sorry, Claire, and I didn't realize it was BYO tech.
No worries, no worries. Go ahead, Leslie.
I just don't understand what this 9416 statute means.
So it's in 18 VSA and establishes VPQHC as, peer review, confidentiality, quality assurance.
Okay.
The statewide organization, and then provides for the formula for the bill back that comes from industry. The hospitals and insurers contribute to that. Hospital portion is 35%, and the insurers contribute about, 5%.
So that's why you say you're not a state entity.
Correct,
State, but so
correct.
there's nothing in our budget that pays for you.
No.
Okay, got it.
All right.
No.
Just to be clear, yeah,
Yep.
that's what I'm trying to understand.
Right.
Yep, and I'll get through,
Okay.
some more of the details. But, industry partners are, we work very closely with, certainly the hospitals. Most of our work is devoted to quality improvement in the hospitals. I think, Claire, yeah, you can move to the next slide. Our mission is we improve the healthcare quality in Vermont by studying the system and making it better. That sounds fairly straightforward, but it's very complex. And I'll show you some examples. But we have a stakeholder board of directors that includes healthcare providers, the health systems, insurers, employers, consumers. The Commissioner of Health or designee is mandated by the statute, member of our board, as well as a second government position. And we're in the process of recruiting someone for that position, and consumers, as well as a few at-large positions. But we rely very heavily on our board of directors for their expertise, guidance, knowledge, and just ability to do outreach and support our organization.
So you're in, I'm sorry. So you're in statute to have these positions? Okay,
Yes,
okay.
yeah.
All right. I wondered what gave you the authority to oversee and whether we would listen to you. I only say that because you're not a government entity and I didn't know how that relationship worked. Thank you.
Yep. I think, Claire, you can go to the next slide. This group, this is our staff, and I refer to them as the dream team. They are the effort and blood, sweat, and tears behind all the projects. They really make the relationships very valuable. We have 2 nurses, a social worker, a master's of public health, and among the group, we have 3 certified professionals in healthcare quality, with a few more in the works to join those ranks. So we bring very extreme talent to the work that we do, and they really make everything hum. Right. Claire, the next slide, thank you. And the 9416 quality assurance contract we contract with the Department of Health to populate the contract with our deliverables, includes peer review that we continue to facilitate throughout the state. And we've recently undertaken a process to, as a quality improvement organization, we apply our methods to our own work. And we want to understand what current best practice in peer review is. And we're finding some really fascinating new developments that we will be considering for our organization and the state as a whole as well. But we offer that connectivity, especially for the small hospitals where you don't have a large and diverse medical staff to be able to refer cases back and forth. So we want to improve that.
Mari?
Do you have a methodology to ensure or review equity, racial equity in your approach, equity around the disability community?
We've
Equity in general?
Yes, we've just started, we've actually been doing health equity training in the hospitals now for over a year and a half. Dr. Maria Avila has been providing that training for us, and we're moving into a new project through the CDC health disparities funding to further that work and engage hospitals in very specific quality improvement projects. And we've just started the organizational assessments with the organizations. In a recent conversation with one of the hospitals, they said, we have a lot of zeros on the assessment. I said, yeah, don't worry, everybody does. So you're in good company, and that's why we are undertaking this work. Lots of opportunities for improvement.
That's great. And I think I remember talking a lot last year about IRB, Institutional Review Board. Do you connect with them at all, especially around equity issues and design of actual research, not just, I don't mean just that quality projects?
Well, I think I have to I believe the Health Equity Project does have an evaluation piece to the final project that would involve an IRB review and,
Okay,
yeah,
great.
absolutely, yeah. So in addition to peer review, our confidentiality protections provides that space to be able to have difficult conversations about safety events, issues, case reviews. We meet on a quarterly basis with the quality directors of all the hospitals. We also meet with the care transition leaders. And I have to say, both of those networks really are looking forward to being able to meet back in person again. They enjoy the camaraderie and just being able to chat with each other, share pains and improvements. And both groups, we host password protected portals on our website so they can exchange resources. Nobody has to go back and reinvent the wheel for a policy or procedure. A lot of open exchange, which really helps share the workload.
That's
great. And they really appreciate those resources. We also have the telehealth and healthcare quality analysis. That should be coming out, I believe. We just extended the contract an extra month or so. So that final analysis will be coming out soon. And we'll have a piece that will relate to the audio only utilization as well. We also provide technical support to the hospitals and their infection prevention staff for submission of information to the National Health Safety Network, NHSN, which is based at the Center for Disease Control, the CDC. We help with just hospitals' access to the systems, and then we do validation of their events to make sure that what's in the system is accurate for each of the organizations. And then we call it the huge bucket of just technical assistance. And that is kind of answering the phone when the phone rings, whatever questions, issues, new adventures, our hospital partners may have. We kind of we catalog all the assistance that we give. That is, I have seen for an annual, the full report for 1 year is over 4 pages of single space lines.
Wow.
So we do a lot of support, I would say kind of off the cuff. And sometimes that's where our projects come from. It starts as a small, I have a question that then evolves into a little more research and digging in. And then if more of our hospital partners have the same issue, then it can evolve into a full project.
I have a question. So is it only hospitals that you work with, or would you work with an FQHC or a DA or another piece of our healthcare system?
We want to reduce silos, bring services together, reduce duplication. So where we can facilitate partnerships and bringing people to the table. Bi-State is represented on our board, so is the Vermont Care Partners.
Okay.
And we look all the time for opportunities to partner together.
Great.
With both those organizations.
And so for those who don't know, Bi-State is the organization for the federally qualified health centers in Vermont. And Vermont Care Partners is the organization for our designated agencies, and both will be coming in to talk to us soon.
Within the hospital, there's nurses, there's all kinds of employees. Do you review how a nurse, how they show appreciation for the nurses' activities of the work that they do? and other people in the hospital to make the hospital run.
So
Who
through,
does that? How does that happen?
so the hospitals really do that themselves through their.
So if they don't do it, is there any check on that?
Absolutely. We monitor what's called their HCAHPS surveys, and they also, as part of patient safety improvements, do a culture of safety survey. So staff are encouraged, and closer to 100% is the desired, response. As many staff as possible to kind of weigh in on the culture of safety survey so that they can express confidentially any concerns that they have about their working environment, needs they see in the organization, feedback to the administration. And those surveys have been very valuable in educating, management and leadership about needs in the organization. And then we monitor through the hospital community reports and the Medicare Beneficiary Quality Improvement Program, their responses on what's called their HCAHPS surveys. And HCAHPS is the Hospital Consumer Perception of Satisfaction. I'm forgetting one of those letters, but they routinely, and Mari's probably very familiar.
I am, and I can't remember the,
Yeah.
So is this something that I
Healthcare.
fill out?
I'm sorry?
Is this a survey that I fill out
As
as
a
a
patient?
patient?
Yes.
Yeah.
If you,
Familiar with him. Okay, but my interest was, somebody like Mari, let's say, is a nurse. And I know that within the hospital complex, I think it's important that people are appreciated. And it happens often. Not just with the bonus or something like that, the culture that's there.
Yeah.
So I was just wondering if anyone checks on that. I have a daughter that's a nurse, and I hear an earful of, do they appreciate, do they not appreciate?
yeah. And we've had, this period of the public health emergency and COVID has been
Yeah.
incredibly stressful on hospital staff and especially nurses. And where we don't have an established program right now, any hospital that would like some assistance, we're very happy to support any way we can. We work very closely with VAS and support any programs that they have initiated as well.
And VAS is the Hospital Association.
I'm sorry.
That's okay.
I was going to say, you're allowed to kick me under the table for
Yes.
using acronyms.
Yeah, no, that's okay. We're trying really hard to make sure we're all, but yeah, and it's Vermont Area Association of Hospitals.
Vermont Association of Hospitals and Health Systems.
I always get that one wrong.
Yeah.
It's alphabetical, great.
Another example, and this is indirect support to the staff with pediatrics boarding in the emergency departments because of the delays in being able to discharge kids to appropriate settings for continued care. Has just become a management boredom, really difficult circumstances, as I'm sure your daughter can attest to. And VAS and VPQHC, VAS approached the Vermont Community Foundation for funding for what we called the Kid Kits and their activity boxes. And we were put in cardboard boxes with coloring books, decks of cards, age appropriate, safe. We had these reviewed by our attorney just to make sure there's no safety issues and so forth. But it was based on a program at Boston Children's. And we assembled and distributed over 1,300 of these kid kits to support the staff managing these individuals in the emergency departments. They have been wildly successful, and we have a request for another 1,000 kits. So it turned our offices into this mass production center.
That's great. Daisy?
How do you measure success of something like that?
I think the thrilled people that, well, upon receiving those kits, we've received emails, letters, calls. It would be hard for us to, we wouldn't be able to do a customization of the patient satisfaction surveys because that runs into logistics and cost and all kinds of things. But the response and the feedback has been phenomenal. I mean, literally, a delivery came, they tore open the box and handed a kit. And, 3 age groups, age group from 3 to 6, which is still mind-boggling to me, 7 to 12, and then 13 to 18.
So you do get feedback about them?
Yes.
Okay,
Yeah.
that's good to know that.
And I think even though that's indirect, it helps the staff in the emergency department to deal with a very stressful situation, both for the child and for the staff.
Because before this, the children had nothing. So they're waiting in a room, probably scared, going through a crisis. And there was nothing at all for them. So, yeah, it's been great. Good. Any other questions right now on this topic? Okay.
And just one final thought on the 9416 bill back contract. We will be, we're in the process of requesting an increase. We have not come to our stakeholder partners since its inception for an increase. And we're at the point where that would be very helpful to stabilize our funding as we continue to grow and evolve to meet the needs of the healthcare industry here in Vermont. So you may see us again with that hat on.
I do have 1 second, Joe, and then I'll get to you. So I do have a question on that. So and I may have missed this, I apologize. Is the bill back percentage in legislation?
Yes.
It is, okay, so it would be,
Portions of the formula.
okay.
Yeah.
Yeah, the portions of, like it is for the Green Mountain Care Board.
Yes.
Very similar. Okay, thank you. Go ahead, Joe.
Please define bill back, please.
Oh, yeah.
So it is a bill to our industry partners. They call it a tax. I call it a helpful funding. And the hospital portion is 35%. Currently, our amount is $660,000. The hospital portion is 35% of that, and it's distributed based on their annual discharges. So UVM has a very large bill, Grace Cottage has a very small bill. And the insurer portion is based on their paid premiums. So that's how it, is equitably distributed. Thank you.
So that's a bill that you send for your services? Is that what you're saying?
Yes, we don't do it. The mechanics of sending the invoice actually has continued to stay with the Department of Financial Regulation. Yeah,
They
DFR.
send the bill for your services to the hospital, who then pays you.
But we contract with VDH
Right,
for the content of what we do. So,
Okay.
yeah,
okay. All right. I'm just trying to get the finance.
yeah, it's a
Okay.
little bit of a
And
triangulation.
is it a yearly thing?
Yes, the funding, we've
Or do you go in yearly to hospitals?
Well, we go in kind of constantly.
All the time.
Oh,
Yeah,
okay,
we
okay.
never really stop.
Okay,
What we do have is, I believe they're billed annually. I don't think they've ever sent a bill for a 2-year period, but our contract of what we will do is structured for a 2-year period.
okay. So I just want to understand what you do. So I'm a hospital administrator somewhere, and all of a sudden you show up at my door and say, this is a quality check on what you do, or you come in and we talk about the system, or you show up unannounced, is it planned, or is it?
So it depends on the contract. The answer is yes, and it depends on the contract. And Claire, if you go to the next slide, this will start to give you an idea of, as I said before, 9416 is capped at 75% of our operating budget. So we have to go out and find more contracts. One of the contracts we have also with the state, we're a subcontractor to Vermont Department of Health for the patient safety surveillance and improvement system. And that is and that's in statute as well, that is mandated serious event reporting. And under that program, we do go into the facilities. We have always shown the collaboration of scheduling in advance for our site visits. I think maybe once or twice, we just weren't having responses on the hospital side and went in when it was convenient for us, which is actually a kind of helpful way to do it. It becomes, kind of gets the organization up on their toes to have that constant readiness.
Okay.
And, but usually we, collaborate to have mutually scheduled convenience.
Okay, we're gonna just take 1 second here. Go ahead. There's a lot of notices going up.
Thank you. What's the bill?
Yes. I can help you.
That was the old way. Oh, that was the old way. Thank you. No.
Yeah, she's Leslie Goldman. I know, I saw you had her.
We help.
I do it.
We'll just pass them on.
We get suspicious when everyone gets weird packages.
All right, so we're gonna let them work that out.
Is this happening?
I just wanted to follow up on Art's question
Perfectly.
because I too am sort of trying to understand this, and so I just wanted to bounce off. So I just want to sort of state my understanding. You can correct me if I'm wrong. So under statute, every hospital and insurance company in Vermont must give you money based on a formula, and that formula for hospitals is based on their annual discharge rates, and for insurers based on paid premiums. However, that is capped at 75% of your funding. And so the next portion of this is you have 25% more of funding. And so you find a variety of projects that sounds like typically comes out of the work that you're doing already, that you might say, I'm just trauma-informed care training, something I care very much about. So, oh, wow, there's a need for trauma-informed care. So you will then reach out to Department of Mental Health in this particular thing and say, we want to partner with you and get a contract with you to do this training, and they will then contract with you.
We were very fortunate. You've got it spot on, with one exception.
Okay.
Department of Mental Health approached us,
I see.
which we really like that.
And do they typically approach you, or do you typically approach them, or is it just?
It's a mix.
Mixed.
It's a mix.
Yeah.
Very often it's, arriving at a mutual, say, okay, here's a logical next step. This is working. We need to expand this. Let's go find funding.
And then, so it sounds to me there's your main set of programs, which is what we saw on the previous slide. And then those are sort of under your 75% basically. And then there's your 25%. So to follow up on Art's question, it sounded like he was asking about, you arrive unannounced, do you do this, do you do that? And so I'm wondering sort of, it sounded like what you said, and I was just trying to make sure I understood this, that, in your 25% programs, the one we're seeing right there, there may be some situations where the contract calls for you to show up unannounced. There may be situations where not, but under your 75% stuff, that is more sort of that interactive stuff you were talking about a moment ago. People
Yes.
calling you for technical support,
Yep.
or you reviewing these patient surveys, these safety surveys and things like that.
Exactly.
Okay, great, thank
Yes.
you.
Yeah, and those quarterly network meetings with, we tend not to meet with the CEOs. That's something that, we've just started recently. And they've not known very much about the value of the work we bring into the organization. We work more closely with, or very directly with, the quality directors, the regulatory folks, patient safety folks, infection prevention folks. and the care transition leaders. So we work at that more operational level on a variety of many different topics and projects.
Thank you.
And that's at 25%.
That's great.
Nope, being done. So in addition to the patient safety surveillance and improvement system, we work with the State Office of Rural Health. And this is where we are tremendous partners with John Olson. I imagine you'll have John come in and share some of his programs as well. But he's been wonderful in supporting the small hospitals, that rural health funding that we leverage in many different programs in the form of mini grants, which is, here, do a QI project and get paid cash that we, facilitate through those contracts. As I mentioned, the Medicare Beneficiary Quality Improvement Project, we call it MBQIP. That's where we monitor their quality and the patient perception of satisfaction as part of those, metrics that we follow. We prepare a dashboard of that information, and we turn this information back to the quality directors so they have a good understanding of how they're doing relative to their peers. That helps spark improvement as well.
Leslie, and then Daisy?
Could you talk about how you get your data? Because we hear a lot about data and how good it is and VHI and all these different places. So can you talk a little bit about that?
So we go all over the place for data. We work with the Green Mountain Care Board, their data analytics. We'll work with VAS to get hospital discharge data sets, very targeted to the project the project at hand. We'll often do our own surveys and, wherever we can leverage data where it already exists, we try to avoid additional burden anywhere we can.
Thank you.
Absolutely.
We're good? Okay.
Okay. We also work with VDH on the Health Equity Grant. This is a new project that's just starting. I think I mentioned the hospital organizational assessments, and everyone's starting to learn where their starting line is and moving towards what will be, each hospital will be able to craft their own QI project based on their needs, their culture, and the direction they want to take with that work. But we'll centrally monitor that information. The CDC, John has also supported the suicide prevention grant funding. Very interesting blend of 4 different funders that came together for that work. And absolutely, I'll get into a little more of the details with that, but very, very necessary. And Joe, you mentioned the trauma-informed care. A great example is that work that was just concluded or is wrapping up at the University of Vermont, is when Department of Mental Health said, okay, we want all the hospitals, we need to right-size this for the mid-size and smaller hospitals. Who can help us do that? And it was VPQHC. So we were thrilled to be able to partner with DMH, and we're just getting that. We're in the process of doing the contracts and subcontracts.
Would it be possible to connect on that? Because it's an issue of great importance to me. So
Absolutely.
It would take too much time here, but great. Thank you.
No, absolutely. And we can keep you, regularly updated.
Please,
So,
I appreciate that. Thank you.
Terrific.
Bobby?
The quiet kids listed there, that's not the same as the kids you're talking about for the kids, is it? That's a different.
Yeah, the quiet kits were for a similar process, putting things in a box, because one of the patient satisfaction scores that we've had a difficult time moving the needle to make it better is the level of noise. And you don't want a noisy environment in the hospital when you're recovering. So we had a project to combine, I think there were eye masks, earphones, earbuds. I'm trying to think of all the materials in it, but again, distributed to help those patient satisfaction scores, make patients more comfortable, with the louder noise levels.
Oh, yeah, the hospitals are loud.
Oh, yeah.
BP.
And there were a series of posters. We had fun picking these beautiful, like, pastoral scenes and, you know, with the message, you know, silence your cell phones and, you know, these are quiet hours, and, you know, being able to distribute those to all the units.
Important. I'm very sensitive to audio, so I would be very appreciative of that.
Oh, good, yeah, good. Well, hopefully they're in place. And probably the last thing I want to mention, we also work with the Vermont Department of Corrections, a separate contract with DOC to help them with their peer review, case reviews, and we'll be going into a new phase of doing some, you know, traditional quality improvement work with the Department of Corrections.
Is there any more you could say about that now, or would it be better to come back and talk about it?
What I'm very happy to say is that we've been able to support them through a couple of challenging situations that just needed some process work, and we kind of helped facilitate that. We were able to bring community best practice into the correctional setting and kind of raise the expectations of, as you know, as you're reviewing a protocol, we expect the same continuity or comparability to a community standard for. So that was, I think, an elevating conversation, and we could probably talk a little more offline or another opportunity, but we continue to support their efforts, and we've had a very substantial increase in the cases that we've reviewed. In years past, it's been kind of minimal, and it's not anymore, and that's a good thing.
Yes.
Definitely.
Yeah. So. We also have been able to secure some private philanthropy that is directed and devoted to the independent mental health provider population to provide collaborative assessment and management of suicidality. The motivation behind this is that some of the work in the emergency departments relate to mental health issues, and we'll go into some of the information around suicide. Being able, as an emergency department provider, to have good confidence in a discharge and handoff to a community-based provider that has the comfort and confidence in managing suicidality. So this program has trained, I believe, over 300 independent mental health providers. And at the end of, at the conclusion of the training, which involves 8 hours of a very immersive experience and continued community of practice support, we ask that these newly trained independent providers put their names on a listing of who's available in your area so that that information can be available to emergency department providers. Some willingly add their names to the list, and others, we're still waiting and hope that they will come along and join.
Is this the telepsychiatry network that you're talking about?
Not yet.
Okay, that's what I saw. Okay, so I just wanted, so what you're talking about, is it up there?
On the next slide.
I'm sorry, one more slide, Claire. My apologies again. Oh, you know what I skipped over, and you can leave the slide here. We have received federal funding from our congressional delegation. We have $900,000 from Senator Leahy's office for the Vermont Emergency Telepsychiatry Network, and I'll go into more details in a second. And from Senator Sanders, almost $500,000 for a continuation of its telemedicine access project, the VTAP. And that's a modification of what we did with the Connectivity Cares packages back under the public health emergency.
If you can just do it, because a lot of folks weren't here, then if you can just brief what that was.
So,
So it was really important.
yeah, that was, it's a little bit out of our typical wheelhouse, but what we did was there was a gap and a need, and we stepped into that gap to address it. Under the coronavirus relief funding, through the Energy and Technology Committee, we received an allocation of $800,000 to distribute digital devices with literacy educational tools in a backpack with hand sanitizer and a notepad and some other materials for vulnerable Vermonters to be enabled to continue to have connection to their providers for complex care when they couldn't go into the offices. And, they didn't have digital equipment. So this backpack provided that connectivity for continuity of care. And we distributed over 1,500 digital devices, 550 Wi-Fi boosters into congregate living organizations. I know in the middle of the pandemic, my own father was hospitalized in a rehab center following an event. And, it was one of these, they had to put him near the window, put the phone near the window because only that wing of the building had cell service. And it's like, are you kidding? So, now we try to fill in all those blank spots here in Vermont, distributed over 550 Wi-Fi boosters. I was kind of hoping I could shoot one down to New Jersey. Listeners at home would have made life a little simpler. But that was a phenomenal project.
Yeah.
And again, we turned our space into this production center. We had cardboard boxes stacked up the walls and delivered.
It was really, really important because so when that happened in March and we had just passed out of this committee, a telehealth bill had just passed the floor. And that telehealth bill expanded the use of telehealth with the understanding that it would take us 5 years, most likely, to be able to fully use telehealth because it was just such a novel idea and we had all these problems with technology. And then the pandemic hit and everyone's like, oh my goodness, how do we stay in touch with our doctors? And so we passed the necessary legislation to make that happen. And then your organization came in and helped our most vulnerable be able to stay in contact with their doctors. I mean, it really was incredibly important, the work you did on that.
So thank you.
Yeah.
And, during that period, we were meeting with the Vermont e-connectivity group. And I love kind of left-handed compliments. The Department of Libraries copied our project with the Connectivity Cares packages and did the same things through the libraries. So, it really blossomed from that original idea and was just, yeah.
So this funding from Senator Sanders' office is continuing that now, or?
It's modified a little bit. We were assigned to a USDA program that it had all these requirements. So it kind of morphed from what the Connectivity Cares package actually started out as, but we have a couple of ideas on that, and became more of a hub and spoke and equipment more now for organizations to be the hub home content. So several of our hospitals are hubs. I'm trying to think of all the SASH will be a hub. The People's Health and Wellness Clinic in Barry will be a hub that will then extend the use of their equipment to spokes.
Right.
So it's a modification, but VPQHC is also partnering with the Equal Access to Broadband organization that's newly stood up. We have a small USDA contract to help them form up as an organization. We think we've got a pretty good track record and we're okay to coach someone else. And they would be the best new home for CCP, for the Connectivity Cares Package. I've often called Connectivity's care package as, it's the last 10 feet from the plug in the wall to the chair.
Right.
And, they offer the subsidies, they can, provide equipment for, vulnerable Vermonters, because at the end of the program, we still had probably over 3,000 contacts that, of unmet need. So we'll be supporting EAB in their efforts to probably look for funding to go back to the classic Connectivity Cares Package program and continue the implementation. And we'll be coaching and supporting them in that.
That's great. Great. Thank you for telling us about that.
Oh, absolutely. Absolutely. So the other piece about the VTAP allocation from Senator Sanders is that it doesn't have support. It just pays for the equipment, doesn't have support for our time. And, we wanted to include literacy and resource information with that equipment. So we're still looking for some funding to make that project whole for our organization.
You didn't get any of the federal COVID money through the state?
We may circle back. Well, through the, for the Connectivity Cares Package of funding, we did. But when we were assigned to this USDA program under the Sanders congressionally directed spending money, that program didn't allow for personnel.
For human resources.
Yep. So we're still looking for that piece. So if anyone has any ideas, I'm all ears.
Well, one of my questions is a legislative ask. So as you think about that, is that something we should think about?
That would be great. And we can form that up. We have the information available. And, we've tapped several partners to look for that information, including that Vermont e-connectivity work group. So,
well, I'd be very happy to.
Okay. Thank you.
Yeah.
Yes, that would be great. And as I mentioned, private philanthropy, we've done the CAMS training and the activity kits. And we've, the private, the Vermont Community Foundation has also contributed to the suicide prevention in the emergency department work. And then finally, we have a regional partnership regarding quality. I just wanted to point this out. It works very closely with our patient safety surveillance and improvement system. It's it's funded through CMS, which is a federal partner. But it's the prime owner of this contract is the Hospital Association of New York State. And there's 6 states involved in the Eastern States Quality Improvement Collaborative, EQIC. And they also drive resources to the hospitals related to patient safety, harm reduction. And our lead nurse, Lindsay Sykes, does both of those programs. So she's able to direct those resources to our hospitals.
That's great. Daisy?
I'm glad you went a little more big picture. I'm really curious how the role of the organization, how much of what you do is really facilitating systems learning and how much of what you do is really kind of filling the gaps between federal compliance and regulation?
Significant amounts. And part of the patient safety surveillance system is we go in to review their comprehensive event tracking and understanding their minor safety events up to their serious adverse reportable events. But we also do what we call a mock survey for conditions of participation. So we will partner with the hospital, and it's usually scheduled for what we call a mock survey. And we come in as if we were surveyors. We put that regulatory hat on. We, kind of like your auntie's white glove inspection. And but we leave them with a comprehensive report of our findings that then they can use as a work plan for their specified improvement needs. and those gaps in that compliance.
Good. Art?
Kind of a follow-up to that. When I see quality of, what's your organization's name? I gotta relook it up. Quality assurance or quality of care. How much do you get into, you probably don't, I guess, get into the decision-making around the patient's actual health? You don't do that, do you, or do you? The physical therapy that's given a patient after a joint surgery, whether to do this or to do that, whether this evidence maybe of a cancerous cell is enough to require X type of treatment. Do you get into those type things or not?
So to a certain extent, that's what peer review focuses on. And we don't directly get in between the provider and the patient. It's more, and from a systems perspective, it's how effective is the system in meeting the patient's needs.
Okay.
And then in our patient safety surveillance and improvement system, where hospitals are mandated to report serious adverse events. So a fall with a fracture. I had a recent hip replacement and I insisted on getting myself out of bed, and I was supposed to call for 2 nurses, and I didn't do that, and I hit the floor.
You don't know how close to home that is.
Well, and that's a serious reportable event because that should not happen in a hospital. And that's where we can support the hospitals in, okay, did you look at all your systems? Was the patient told? Was the call button within reach, that.
Okay, those things are kind of structural around safety more than, but you don't get into a doctor's decision-making or any of that, provider's decision-making.
No.
Okay, thank you.
But only in as much as if there's new best practice. We would take a role in disseminating new best practice.
And it comes to mind, if we're gonna, we're moving from fee for service to healthful quality. I mean, are you involved in that at all? Where instead of fee for service, a provider is providing overall health. Do you look at that at all?
So I think that's where we're starting to evolve. And what I think about in terms of value-based healthcare quality, it's doing
Value-based, that's the word.
the right thing in the right setting, for the right duration, for the right patient. It's doing all the right things the first time and every time. And that's quality and equity. So everything is available to the patient and at the time they need it in the right amounts.
So that's something you do look at? You're starting to
more
use
and
that
more, yes,
more,
more and more. Yeah.
So you would probably have to, create a program for that, I assume.
Yeah.
You're gonna have to put something together that takes all that into account.
And I think that a very necessary component of that is real-time data. And I think the hospital organizations we can support the hospitals to be able to do that within their own house.
Right.
But how can we drive resources and training and education to the hospitals so that they can conduct these analyses?
Right. Although it's always good to have an outside vendor come in and look.
Yep.
But, yeah.
And that's another good description of DPQHC. We're a neutral convener.
Right.
We can bring many diverse voices and discussions and positions to the table.
Yeah.
And we will often describe ourselves as Switzerland, minus the chocolate. But
Well, we have chocolate here.
okay, but enabling the hospitals to take that journey. And for me, value-based quality care is the business case for quality.
Okay, thank you.
Okay.
Yep.
So-
Great, let's keep,
This is very quick, but you brought it, she brought it up. So you, the system failed you, or you failed the system, you fell.
Oh, that was hypothetical.
Oh, okay, got it.
I had a very successful hip
Oh,
replacement.
sorry. Okay, I thought you were-
Just,
okay,
no, just an example.
Okay,
Yeah.
got it.
But I have received many calls personally as, Kathy, this happened, what do we do about this? And it's a very touchy.
Personal, I was just thinking about a personal analysis, so that's fine.
Yeah.
Got it.
Yeah.
Well, I'm very interested in I want to make sure we move forward because I'm very interested in the suicide prevention and EDs data, and then also to make sure we get to the telepsych because.
Absolutely, absolutely.
Too.
So if we could, Claire, thank you. This will give you an idea. This is how we kind of prioritize our work. Here in Vermont, suicide prevention is very important. And the ways our projects arrive usually have to do with data. Data-driven decisions. This example is a very important one that, so much of visits to the emergency departments and suicide in Vermont often have decedents have been in the emergency department within 365 days. So that provides a tremendous opportunity in the emergency department to train up and prepare staff. Because typically emergency department staff are not trained in these skills. They're trauma-based care. And that's what an emergency department is for. So these projects are bringing best practice into the spaces where it's really needed. And Claire, one more click and we'll get the additional, and this graph on the right shows that the rate is increasing. And, this prioritizes the work that has to be done.
Can I just clarify? So in the emergency department for any reason? So I'm like, they could have broken their foot
Yep.
10 months ago?
Yep.
Okay.
Joint Commission now has a standard where you're asked about your mental health on every hospital visit. And at one time I was questioned, like, isn't that unnecessary? And I really truly feel that in any 10-minute segment of someone's life, things can change. And that becomes a very important question. And I support that standard. I think it's important.
Just a clarifying question.
Yep. And then Claire, the next slide. What this slide shows you, and this is a great example of how our process works. To start a project, we recruit the hospitals and ask for a letter of intent that they want to join this effort, and they're kind of acknowledging that it's going to take, time and attention. We often ask for a contact person or a champion for the project. And then we distribute the organizational assessment. And it was fascinating to review the compiled organizational assessments because the tool showed the roadmap of where the hospital stood. They, self-assessed, completed the organizational assessment, and right there, here's where best practice is, here's where you are. And,
Just real quick, is it true that that's where you might see clinicians don't feel comfortable asking someone if they've thought about suicide lately?
And that's what all of this training has been to address, to improve that comfort and competency with things they're not familiar with and now have to address routinely. Okay. So then we feed back the information from, each hospital gets their own report back with the aggregated information. And often it takes a team of people in the hospital to thoroughly complete the organizational assessment. And then in a project networking meeting, we review the group's performance so that each hospital can see their benchmark and where they stand within their peer group. And are they a leader or a laggard or mid-pack? and what they need to do to improve their position and understand, their hospitals, their organization's gap from best practice. And then they design their QI project using
What does QI stand for?
quality improvement.
Okay.
And PDSA is Plan, Do, Study, Act, a very kind of basic progressive tool, make a plan. How do you think this is going to go? What's our baseline data? That's the do, study, let's do the implementation and then, follow up and how did our theory work out? How does this new change impact the work? And then we've had periodic networking meetings where the hospitals share their projects and then received feedback from a national subject matter expert, Dr. Edwin Boudreau from the University of Massachusetts. He was a tremendous asset to this project. And then they submit a 3-month update and then their final report, which Hillary was working on as I left the building last night. So this is a good example of the QI process. I think, Claire, the next slide, and I will tell you, so these are the benefits of the participation in this project. Each hospital that completed that timeline received $12,500 and an additional educational stipend of $1,500 for whatever they wanted to use it on. Conference attendance, a speaker, their choice. And then the Focus Knox survey was conducted in the emergency department to review policy, literature risks, training materials. I'm trying to think, it was a very comprehensive part of the project and very valuable. Everyone, every hospital participated in that mock survey and appreciated the understanding that was gained from it. Of course, technical assistance from our team and the ongoing membership in that peer learning community. And then again, access to the subject matter expert. And then Claire, another click. This is not an eye exam.
You sure?
Yes, it is.
It's actually better than what I see on my laptop. But I bring this up as just an example. This is a tracking tool. This is one of our project management tracking tools and the hospital's performance so that in a snapshot, we understand where everybody is, what's due next. And Claire, one more, we'll move away from the eye exam.
Can I check, Mary? So is this real or is this just
Oh, that's real.
Okay, good. So these are really things that happen.
Yes.
So the numbers 0 to 50 to 70 to 100 is great.
Yep, absolutely. 14 of 14 hospitals were all enrolled in this project, completed the organizational assessment, submitted QI project proposals, all said they were satisfied or very satisfied with the networking meetings, and 100% said, as a result of this meeting, I have a better understanding of suicide prevention practices that can be implemented in the ED setting. That was the goal we started out with.
That's wonderful. Art?
Would you say 100% of all this? I bring a grandchild in and got to cut his finger badly and needs to be stitched. They getting one of these, they asking about suicide or?
Probably.
Really? So everybody?
Everybody.
And that's happening now?
Yep.
Yeah, okay.
Yep.
And how long does this take?
It's part of the intake assessment, and it's really,
Like a couple questions or?
it probably starts with one question, and then depending on the answer,
Yeah.
and I see Mari nodding, she probably has firsthand
Yeah, okay.
experience. And then, you dive a little deeper as needed.
Yeah, okay. All right.
Brian? And then, sorry, go ahead, Alan, and then we'll.
Okay, when like this sentence, when a child goes in here, is a parent there or? Okay.
Usually, I would say
Okay.
usually, yeah.
The
Yeah.
questions aren't on one-on-one with the child.
Probably depends on the age of the child.
Right.
Yeah.
And if I can just, I mean, I have a 14-year-old. We haven't been in a hospital, but every year my 14-year-old goes to the doctors and does a visit, and there is a question that's asked, and they do it very appropriately. And I think it's important because there are children who are in situations that are, they need help. And if the question isn't being asked, then how do you know?
But a 14-year-old might not be comfortable with you beside him.
I'm sorry?
A 14-year-old might not be comfortable with the parent beside him.
Correct.
Or her.
And actually I'm just giving, our situation. I have always been with my son up until he was 13. And then the doctor asks if the child wants the adult with them or not. So it's, I'm just giving my situation. Everyone is probably different. And then that's in the primary care, not in the ED, but just, as someone with a child. Go ahead, Brian.
I have a question and then a potential comment. Are most clinicians, if not all, using the Columbia scale for those screenings?
I believe most are using the Columbia. I know that there's discussion around this, I believe it's the screening tool. I'd have to check in with my staff, but I'm very happy to follow up with you on that question.
Okay.
Yeah.
May I make the comment as a person trained in doing the Columbia scale?
Hold on, did you have a
I
question?
don't know what that is.
Yeah, we don't know what that is.
Yeah.
Okay.
It's a scale used to, would you want to answer it? And then I can, what I want to do is tell them the actual questions so they know what the questions are. But if you want to explain what the Columbia scale is as the witness.
I was going to say, we can team.
Okay, let's do it.
I was going to say it's the Columbia, based from, I believe, Columbia University, suicide scale rating, suicide severity rating scale. Is what C-SSRS stands for. And it's the introductory questions to determine a state of mind, I would think is probably the best way to put it. And your history, your experience with suicidality, current thought processes. I haven't looked at the specific questions in a while. I don't think I could by rote
Well, let's
say them. I was going to say, Brian, you.
And I'm sending them to all members of House Healthcare after I do this. So the first question you ask someone, and you adapt it to age. This is Brian Chino, state representative, for the people watching on Zoom, because I'm not a witness, but I'm trained in this. It would be something like, have you wished you were dead, or have you wished you weren't born? Like, you would ask a question like that. You wouldn't say, like, do you want to kill yourself first? If a person says no to, like, have I wished I was dead, then you would, with a child, it's tricky, but the question for an adult would be, have you thought about killing yourself? The adult said no, you would stop there. If they say yes, then there's additional questions. So you can adapt that with a kid. Usually when I'm talking with a young child, the parent is there. And the way I would frame this is, have you thought about hurting yourself in any way? And usually they're like, no, or they say yes, and the parent is like, and then I'm like, what was it? And then they say, well, I thought about, like, and they say something innocent. You know what I mean? Like, and you're like, okay,
That's what worries me.
Yeah.
So you dig it around so that you understand. Okay.
Yeah, we're very careful about how we do it.
Yeah.
I mean,
Okay.
we've done.
So I'm sending you the questions now, but just keep in mind they're adapted to use.
Yeah. Right.
So, hold on. So I want to make sure that we watch the time
Yeah.
Yeah.
and that we're watchful of us not giving testimony, but I think that was extremely helpful.
That was very helpful.
Marty, do you have something to add?
Just to confirm what Brian said, and I think in our screening tool.
As in nurses?
Yes, the one that I use. The word suicide is mentioned, but also harming yourself. So it's I think initially not quite as direct, and it's leaves some space for a conversation.
And I think what's really important about this conversation and the work that we're hearing from VPQHC is that they are working with all of our hospitals to ensure that emergency room personnel, staff are trained on how to do this in an appropriate way. And that I think is very, very beneficial. Leslie and then Art.
But I just want to say the Columbia tool it looked daunting to me. I mean, it's pretty complex. And I was just thinking that the screening goes first. So I didn't want people to think you go straight to the Columbia tool, that there's screening that then leads to it. Do I have that right?
I don't know, because my job is,
You're already done.
I'm a crisis clinician, yeah, so
They're past the screening, so.
Yeah, that's what I'm thinking. That's
Yes.
right? So I just want people to understand that they're screening one question, two questions, then goes deep because I think someone said you were gonna send it.
I did.
Yeah.
Art.
Yeah, and this question is not my opinion on this subject, but can a parent of a minor opt out for his or her child? Can a parent say, no, I don't want those questions posed to my 5-year-old? Can that legally happen, or I just wonder?
I don't know the answer to that.
Sounds like Daisy might.
As a parent of a 5-year-old, and as someone who has, patient experience myself recently, being in and out of hospitals and doctors with long COVID, and mental health issues, I have had this tool administered to me several times. I would never know it because our clinicians in this state are so fantastically trained. So when you look at this tool that's being sent around,
Yeah.
I would never,
It wouldn't even occur to
it might
you.
look
Okay.
daunting, but it would never occur
All right,
to Art
okay.
that someone had asked me those questions. And I trust our clinicians to do this with my 5-year-old in a heartbeat. I mean, I know 7-year-olds that have attempted suicide. And
Right.
my God, I would absolutely want these questions asked to my
And I
5-year-old.
almost think sometimes, I won't make any judgment. but-
No judgment.
You'd never
I
know
understand.
someone was asking these questions. Our clinicians have got it down to an art.
But at the end of the day, I mean, I do think as a parent, you can have a conversation with your doctor.
Yeah.
I mean, that's, the doctor-patient relationship.
Right.
So I would feel very comfortable, again, this is all, we're kind of going off script here, but I would feel very comfortable talking to my doctor about the questions that are being asked, as I'm sure anyone hopefully would. And if you're not comfortable, then that's another conversation you should be having. So I think the key here is this is what VPQHC is very good at doing. Thankfully, our hospitals have been engaged with them. Looks like,
Yes.
great statistics here that all 14 hospitals participated. And that we have, Daisy, I think you said, someone said, we have very dedicated healthcare workers in our state that want these high statistics to go away.
Absolutely, absolutely. And I would say it's part of a fully integrated, comprehensive systems assessment, a holistic,
Well, it's physical
integrated.
and
Yep.
the mental together.
It's all
Yeah.
one package. Probably the most important thing I want to highlight here, as part of the Suicide Prevention Project, over 200 hospital staff were trained in what's called CALM, Counseling and Access to Lethal Means. And that's essential in building that skill set and being able to have the discussion about, do you have guns in your home? What kind of access? We are also working with VAS, and I'm forgetting off the top of my head who the funder was, but lock boxes and gun locks, and distributing those tools for further distribution to homes that would need them.
Which is,
And then, I'm sorry, go ahead.
no, that's great. It's all fabulous work.
And then the emergency telepsychiatry program, again, evolved from a webinar that was part of our telehealth office series back in the in the COVID public health emergency. But August of 2021, Dr. Sai Saeed from North Carolina, and it's called the North Carolina STEP program. shared their experience in rolling out a statewide, or I believe it may be statewide now. At the time he presented, it was a portion of North Carolina. So the area from Greenville, where he's based at East Carolina University, Greenville kind of east, and that a very rural area of North Carolina. But following that presentation, 100% of the attendees of that webinar agreed that Vermont would benefit from implementation of a program like this. Benefits in North Carolina include a cumulative system-wide savings of over $39 million. Our eyes popped out when we saw that number. And then overturning 40% of involuntary commitments, which is just huge. And then 1,200 patients avoiding unnecessary hospitalizations in their state fiscal year 2021. So if we could have proportionate benefits like that, it would be exceptional.
I think I know the answer to this question, but I sort of just want to state the question for the record because it was confusing me for a few minutes. Emergency telepsychiatry is not the same thing as 988. Is that correct?
Correct.
Great.
So emergency, great question. Emergency telepsychiatry is putting, virtual equipment, and just January 4th, our pilot demonstration between Rutland Regional Medical Center and Brattleboro Retreat started January 4th. The first consult, I think, today's Friday, I think it was on Wednesday. So they're up and running. This is huge. And we're just so excited. Another feature of this, we try to centralize and do the heavy lifting. We've put together the contracts but Rutland really had like a shovel-ready project, but we were able to step in with Senator Leahy's funding. We're now in the process of recruiting a critical access hospital to be the demonstration pilot. But we will be coming back with a very specific request. This funding will end in September, and we need much more time, and especially to expand to a statewide network and continue to grow the services. We'd want to look to a 3 to possibly 5-year window to be able to fully implement. We're just, we'll be able to capture the lessons learned and experience from the 2 demonstration pilots to be able to apply to the growth going forward. We just completed the planning grant that identified 5, program components, the program management, training, the demonstration projects, and then we are calling hospital enhancements so that the hospitals that may not be the initial pilot sites will still get some funding to support either their current if they have telepsychiatry services currently, or to start ramping up towards implementation, and then program evaluation at the end of that. And we're hoping to include the economic impact of this program. So we'll be back with more details on that.
It's exciting.
Absolutely. Everyone was so jazzed when everything happened this week. That's exciting. Art?
Yeah, and this is very interesting to me because I visited the folks at Rutland Regional a couple of summers ago, went to the emergency room, sat in the special rooms they have for the kids who come in with psychiatric problems. But where are the child psychologists located that actually do the telehealth? Is that established yet, or are they out of state? Are they in state?
So for right now, the partnership with Rutland Regional, they're based at Brattleboro Retreat.
Okay.
But we'll be contracting with other vendors. We're also working with Alpine Telehealth as a consultant to the project.
Okay.
And then for for the critical access hospital pilot demonstration, we may need a vendor. And, we'll be asking those questions. If you're dealing with a vendor from out of state, how important is it that they know the local resources? And we've had several,
Okay.
discussions on those features as well.
Now, will they be able to, I hope, lessen the number of kids in the ED? So they're gonna be able to solve the problem with the patient, the child, and hopefully move them out back into their home, I would hope.
That would be,
Or out of the ED to
an appropriate setting.
Yes.
Appropriate setting of care. So it's
Probably.
the appropriate setting for
whatever the
care that is
appropriate
needed.
setting would be.
Correct.
Okay.
Right.
I would add safe and appropriate.
Yes, safe.
So if it's safe
Right.
to go back home and that's
Right.
appropriate, but if a higher level of care
Yeah,
is, a residential site is needed.
So if it's a residential site needed, we're still in that same pickle we're in now in terms of no space.
Yep.
Yeah, okay.
But at least treatment started.
Yeah, right. You've got treatment going on while they wait. which is
Exactly.
key.
The
Yeah.
telepsychiatry network will enable evaluation to get started, medication prescription and
Right.
administration, and, get the treatment started that may hopefully avoid an inpatient admission to enable the individual to go home.
And with that, somebody has to be on site, I assume, to okay.
Yeah.
Yeah, all right, yeah. Thank you.
Great conversation.
This was excellent.
Yes.
Thank you. And
That's
I'm
really, really important.
so happy to have had this opportunity. Claire, if there's one more slide, I just want to leave you with some final thoughts. We're a resource to the House Health Care Committee. We are literally down the hill across from the library. I can be here. It takes me 10 minutes to walk up the hill. So always happy to come and support and help. As I said earlier, we focus on alignment and coordination. So where you see opportunities, please share with us, so we can leverage those opportunities, and we just seek to disseminate best practice across the system. So happy to have met you all and had this opportunity this morning.
Great. Thank you very much, Kathy.
Thank you very
Great
much.
conversation.
Appreciate it.
Absolutely.
I'm gonna take a couple minutes here now because I'm not sure what the weather's gonna do. So when we're having Green Mountain Care Board in here at 1, and then once that conversation is over, everyone can get home safely. So I just want to take a couple minutes on some logistical things. So next week's agenda is posted. We have everything's important, but 2 things I want to call out. One is we will be joining the Green Mountain Care Board meeting on Wednesday so we will watch them. We will not actually be physically in the room where we can ask questions, but we will be watching the Green Mountain Care Board meeting on Wednesday, starting at 2. They are having a national presenter come in about rural healthcare across the country. And then they will have another presenter coming in to talk about Vermont rural healthcare. So I think it's a really good conversation for us to listen to together. Floor is their meeting will go from about 2 to 4:30. Floor is at 3. We will most likely have a bill we will need to vote on, but we've been given permission to be in committee otherwise. So we'll have to just keep it going while we go to the floor and vote and then come back. If you prefer to be on the floor, obviously that is your choice. So, you don't have to be here, but I ask that you're at least here from our committee time from 2 to 3. The other thing we'll be doing next week is looking at the Budget Adjustment Act. So I forget if I've said this, but I've asked Alyssa Black to be the lead liaison with appropriations and Daisy to help her. And so what that means is they will dive into the BAA. We have Department of Health, we have DEVA, we have a couple other different places within the budget. And so at the same time, we will have those agencies come in and review their ask with us. And once that's going to be Wednesday and Thursday, I believe. And then we're going to see what the timeline is to get back to appropriations. The next step after that would be a collaborative conversation here as a committee to look at their request if we have other requests that we're hearing about that are not officially a governor's recommend, and then we need to prioritize what our opinion is most important, and then we get back to House appropriations with that request. So that will happen starting next week. So there are, and I'll try to remember to send them to you, but you can also go to the House Appropriations website and you will find all of the BAA documents there. If you're having trouble finding them and you want to take a look at them, reach out to me, but I will make a note to try and get those to you today or tomorrow. Then the other thing I want to put on the table is tentatively on February 1st, we're going to take a field trip with House Human Services Committee, and we're going to go to Washington County Mental Health Services, which is right here. So it's not far, we can drive. We would spend the day, we're figuring out, or they're figuring out the agenda right now, and then we would be back to be on the floor at 3:00. So you might hear rumors about that, wanted to put it out there. The other thing we have talked about a little bit, but I want to bring up again, is in our effort to work more closely with the Human Services Committee, we're forming a subgroup. Teresa Wood and I, Representative Wood and I met yesterday, and we have, and I apologize because I'm going to say this without having talked to the subgroup first. So newsflash for everyone. So it's going to be Mari and Leslie from our committee. It's going to be Dane and Noah from Human Services. And basically their charge is going to be, and we'll talk offline, is to make sure that the two committees know where there's overlap, where there's interest, where we should be working together. So there'll be times that we may have them in our committee, you both may go to their committee to hear testimony, and then there'll be a consistent report out from all four members to both committees. So this is something we've done a bit ad hoc in the past amongst all the committees, but we're really trying to make it a formal process. There'll be a written document you have to report out on, just to, we're connected. Human services and healthcare is so very, very connected. So those will be the two people from our committee. There is still committee liaisons to talk about. We do try to have one person kind of watching other committees. So judiciary would be important this year because of some of the bills they'll be taking up. Commerce is usually important because they take up insurance. So we'll talk about that next week and take volunteers to do that. And I think that's it. You have anything, or you have anything?
No.